the 3% increase in taxes, will the employer pay on their tax return, or will the employer have to withhold?
This is on the 3.8% tax?
Increase in tax.
Okay. So if we're talking about the 3.8% tax, that's that tax on unearned income. So that's not a tax on wages. So the employer will not withhold on that. That will be something that will be calculated on the individual tax return. And it'll only apply to those, well, in my examples, I doubt I've listed every possible example, but it'll only apply to that type of income there in the middle of the page. On the 0.9% tax, that one is on the earned income. And so for someone there who is a W-2 wage earner and they are subject to that tax, they do pay the additional 0.9%, but it will mechanically, it'll work through the system that the employer will be withholding that from them, just the way their current employee portion of the FICA and Medicare is withheld by the employer and remitted on their behalf. So it kind of depends which tax we're talking about, but the 3.8% doesn't have anything to do with the employer. So,
what's the comparative effectiveness fee, and who is it paid to?
That is a fee that will be paid by employers, and it'll be paid, for all intents and purposes, based on what we know today, to a regulatory agency, because a lot of new agencies are going to be created at the federal government level because of healthcare reform legislation, and this particular agency will be charged with studying medical outcomes and effectiveness of procedures so that recommendations can be made going forward. So these fees are in place to help fund the creation of that new federal regulatory agency.
that's on slide 13 there.
Right. How can an employer, I'm sorry, are we complete with that one? Mm-hmm. Good. How can an employer remain grandfathered if we cannot control the provider's charges? For example, the plan pays 80%, the provider charges $100 during 2010, and in 2011 the provider increases their charge to $130, makes the employee pay more out of pocket.
Yes and no. Because what the trigger is for losing your grandfather status relative to that cost share is based on the co-insurance percentage you have established in your plan. It's not based on whether there are price increases or decreases in medical costs themselves. So if your co-insurance is 80-20 and that provider charges $100 for that office visit, you've got the discount from insurance, you're paying based on an 80-20 level. If the next year that same office visit is $130, but you've maintained an 80-20 co-insurance structure within your plan, you haven't triggered loss of grandfather status. Even though the employee could end up paying more based on their 20%, if that negotiated allowance is higher, it's the percentage itself that is the benchmark.
The 0.9% increase in Medicare tax for those who pay, is it on all income or income greater than $250,000 a year?
For married filing joint, it would only be on income greater than $250,000. So again, that if you're married filing joint, the earned income from both spouses would be added together to determine are you over the 250, but it will only apply to the amount over $250,000. Okay.
Please explain what the medical loss ratios for insurance carriers are, referencing the 2010-2011 timeline slide. What are the current wellness program rewards? Also, that apparently two different questions. The medical loss ratios for insurance carriers.
Well, obviously I have not mastered the art of this slide forward and backward, so my apologies if I'm giving any of you headache. The medical loss ratio provision applies to insurance companies, so this would be in the fully insured environment. This is not applicable to the stop-loss market, to self-funded plans, and it really defines what the profitability margin for insurance companies will be, because they're going to be required to look at the premium to claims comparison, which is basically the foundation of how premium levels are established. for you as an individual group or within a pool. And so on their whole book of business, not individually by group, does this provision apply. So their entire book of business, there are established loss ratios that are going to be considered acceptable under healthcare reform. And should their loss ratio, that premium to claims comparison, actually be lower than the established threshold of reform, they would have to refund that difference to their population. So don't fall under the misperception that you as a group is going to be factored individually and then that comparison will be done. This is on their entire book of business. So I think in a minimal way, what this will do is it will result in the tightening up of administrative practices. The regulators are taking comment on how this should be calculated and what factors they'll be allowed to take into consideration, such as clinical programs, disease management, wellness programs, etc., in order to manage their population. That should be a positive thing. And so we're still waiting on the final clarifications, but I think it will change the landscape of how insurers interact with their population a little bit going forward.
What are the current wellness program rewards?
Currently, for bona fide wellness programs, so you're meeting a specific set of criteria, it's 20% of the equivalent premium that you're allowed to use for incentives. And if you'll remember, what we ended up on in 2014 is that amount going up to 30%, assuming you've lost your grandfather status, with the option based on clarifications from the regulators for that to be 50%. Now there's also in play wellness grant program available. This is specifically for small employers. It's a pre-funded program with a limited amount of dollars available for employers who've not promoted wellness programs before in the small employer arena to take advantage of.
A couple more questions. A non-grandfathered plan, PCP designation for plan participants. Are they allowed to select a non-contracting physician or physicians?
Yes and no. Seems like that's been a common thread today. But what it says is, first of all, if you're in a PPO plan where you're just working within a network of providers, it doesn't really change anything, because it basically allows the member or the patient to select any willing primary care physician within your network. So you can still have in and out of network benefits. It doesn't change that. If you're on an HMO plan design, it's any primary care provider within your HMO network who is accepting patients. So I think this is a provision that was probably born from something that occurred on the East or West Coast that we really don't see in this marketplace, because there was really no reason here to have that provision put in healthcare reform. It's not going to change your landscape.
One last question, and it's regarding the nursing mother category. We have a nursing mother who prefers a spacious restroom due to sink access. If she signs a note saying as much, are we protected? And there is a private room available.
I think as long as you have made the required facilities available and the nursing mother chooses of her own volition to use something else, and you document that carefully, you've probably met the requirements of the law. You're just required to make that space available to her. You don't have to twist her arm and make her use it. So that's probably sufficient.